Welcome everyone to our journal club for November 2024. We are really lucky to have with us today our special guest, Dr. Leonardo Manzari, who is a very esteemed lecturer, physician, researcher, many hats, no question. And I myself, of course, am Helena Esmond, physical therapist, and just lucky to be along for the ride to talk all things vestibular. So I'm going to ask Dr. Manzari to tell us a little more about your background and how you got into vestibular care.
Hi, I'm very glad to be here this Italian evening, of course, and I'm very happy to be with you and to share my knowledge about the topic of the month. Yes.
Perfect. All right, so the topic of the month, as we say, is the clinical use of the Suppression Head Impulse Paradigm in patients with vestibulopathy, a systematic review. And Dr. Manzari and his colleagues collaborated on this work to help us better understand this fairly new test. This is not something that, at least as a physical therapist, I'm seeing in the clinic at this time. I know some researchers and some physicians and clinical healthcare providers are using this test, and this kind of additional information could be very valuable. And we're going to learn more about why. We're hoping to see more of this in the future, getting more folks trained on how to do it so that we can get more complete information when we're trying to look at what's going on with our patients and can we use that information to help them better with their rehabilitation and overall patient care. So let's talk a little bit of background first. I always like to start with the slides of getting everyone on the same page, as I like to say. So we're going to talk about vestibular anatomy just very briefly, because we have such an array of folks who watch this. So in our inner ear, we have our hearing structures, and then neighbor to that is our vestibular apparatus. It's a beautiful structure, tiny, but a really big job. And its job to help us sense movement and where we are in space and kind of integrate that information in the brain with our vision and information from our joints or proprioception so that we can kind of feel oriented. And so folks who have problems with our inner ear balance sensor, this vestibular apparatus, can have symptoms that could range from dizziness to imbalance to falls, off feeling, sometimes foggy, kind of difficulty finding their way spatially. There's lots of different ways that we can find patients experiencing issues with their peripheral vestibular system. And the peripheral vestibular system is mostly what we'll focus on today because of what the SHIMP paradigm is looking to test. So let's talk a little bit about our vestibulo-ocular reflex. And this is an important reflex for stabilizing our gaze during head movements. So I like to tell my patients, we need the inner ear vestibular apparatus to help us know where we are, but it also has a job of keeping our eyes on something when we move our head. And we want that gaze to stay stable because if it doesn't, we might get a little sense of blurred vision or bouncy vision, things like that. And this is not a really pleasant sensation. It can make it difficult to function in the world as well. So it's a 3 reflex arc, and it does go in through the brainstem on its way back out to the eyes so that we can have an eye movement response. And this whole reflex is very fast. It's the fastest reflex we have in our body, which is pretty cool. So in this, we move our head, and that stimulates our peripheral vestibular system. That's going to send a signal through the vestibular nerve and then into that vestibular nucleus in our brainstem at the brain. And we're going to hopefully get a motor output then of an eye movement to keep our eyes where they need to be and keep everything stable. And so I'm going to go to Dr. Manzari here and just get a little more insight if you have anything else you want to add about what a normal functioning vestibulo-ocular reflex should look like. What do we want it to be doing? What would you say, Dr. Manzari?
I lose my I lose your voice for a little bit. Can you repeat to me?
Of course, of course. So my question to you is, for the vestibulo-ocular reflex, what are we looking for someone who has a normal vestibulo-ocular reflex? What is their experience with this? Would they even know they had one? What's it like to have a normal vestibulo-ocular reflex?
Uh, the normal vestibular ocular reflex is the best way for us to see the world around us. The normal of the vestibular reflex is when the world around us is stable on the retina. Is the best way to see the world around us, and we use this reflex every day, in every moment of our daily life, in our daily activities. And but what we need to do with this reflex is very strange, since many times during our daily life we suppress this reflex. And for this reason, we are here this evening to talk about this very, very important way of use this reflex. We know that this reflex is very important for our central nervous system, but in the meantime, we 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 used to suppress this reflex to obtain what we every day do during our daily activities. Think about uh, when we see a game, a tennis game, or where we see when we read a book on a bus, or many activities, many activities, and and the normal subject are so able to suppress this reflex that we cannot say that the reflex is very important for our central nervous system. For this reason, I think that we must think about this opportunity to talk about this new insight and this new test, to show how we are able to use this suppression to make sure that the world around us will be stable.
Perfect. So let's talk about suppressing our VOR reflex. So perhaps folks out there who are clinicians are familiar with something called VOR suppression or VOR cancellation test. And I'm just going to put my arms right out here and demonstrate it. The one way to test it that I've been taught is you have the person sit and their thumbs are stacked up with their hands clasped in front, and they keep their eyes on their thumbnail and they rotate back and forth. And what we expect to see is the eyes stay right on that thumbnail. So we're not getting little jumps of the eyes. We're having a nice steady gaze of our eyes right on the target. Is that exactly what you're talking about with VOR suppression there, Dr. Manzari?
Yes, but we are able to be very fast rather than this slow movement. We are very able to suppress our VR gain, VR reflex, and this is very surprisingly, because rather than the use of this clinical test, many of us, many of the therapists, many of the physicians did not think about these opportunities, and probably this is the secret, this is the trick of many patients to avoid the damage of the VR gain, of the slow phase of the VR gain, when we come back after vestibular neuritis, for example, or a bilateral vestibular loss, nearly completely bilateral vestibular loss. Why we are so able to to live with this damaged reflex, because we are able to obtain a suppression of the residual vestibular function, and we are able to do this in milliseconds, not in seconds, but in milliseconds, and this is very surprising. But we know this this opportunity, and for this reason, will be very interesting to talk about this.
Wonderful. All right, that's really insightful. So, that vestibulocular pathway, as you mentioned, it does have it's a peripheral reflex, but it has we kind of a loop into the brainstem. And VOR suppression, there's an intricate kind of relationship between the brain and our peripheral reflex. And what we expect to see with a normal VOR is an eye movement that is equal and opposite in direction to the movement of the head. So this is kind of our classic approach in the past when someone's had what you mentioned, which is damage. So if someone does have damage to typically the vestibular nerve or some branch of it, which we would kind of call it many names. I've heard it called an acute unilateral vestibulopathy. Some people in the past have called it a vestibular hypofunction. I've also heard it called vestibular loss. So we have many terms to describe when there has been damage to unilateral would mean one side of the vestibular system. And we're talking about possibly neuritis you mentioned, which could often be caused by a virus or some sort of infection. Also, sometimes a little clot happens to one of the branches of our blood supply that supplies the vestibular system. And last but not least, some types of autoimmune disease also could cause this kind of damage. So we're looking at different possible kind of root causes of damage to this peripheral inner ear balance system. And bilaterally, also this can happen. And causes here can include ototoxicity, so people who are exposed to certain medications, perhaps from chemotherapy for cancer, or certain antibiotics that are very strong. Sometimes different medications can cause this kind of damage to both inner ears on both sides. Or sometimes with age, we do have some vestibular loss that can occur over time. And we do have a reduction in hair cells for the vestibular system. And children who have some sort of pathology that has caused them to have hearing loss will also sometimes be found to have a decrease in vestibular functioning on both sides, as well as those who have had repeated ear infections, bilateral Meniere's disease, or the very rare case where someone has, say, a neuritis on one side and then perhaps sometime later to have that occur on the other side, or need neurodegeneration. So lots of potential causes of bilateral vestibular loss, hypofunction, vestibulopathy. Have I captured those two kind of conditions? Do you have anything else to add on the causes of unilateral or bilateral vestibulopathy, Dr. Manzari?
Uh, yes, we can talk about bilateral vestibulopathy and unilateral vestibulopathy, and for this reason, in the classical pattern of the head impulse test, we can see how the brain substitute the damaged slow phase of the VR with saccades, and
Mm-hmm.
in the past, we think that this is the trick. We think that this is the secret of the compensation, of vestibular compensation. But now we are able to recognize that there is an interaction between the vestibular system and the visual system, and this interaction is absolutely easy to evoke only with the residual function of the VOR gain, of the slow phase of the VOR gain. Just increase a little bit of the VOR gain, of the slow phase of the VOR gain, And we are able to know this, and for this reason, we can perform a very good experience in vestibular rehabilitation with the patient just a little bit after the acute bilateral vestibulopathy, for example, or for just after an acute vestibular syndrome for due to vestibular neuritis.
Definitely. Yes, agreed. And again, autoimmune disease, I left that off, also can cause bilateral loss. So you've already alluded to this beautiful head impulse test. So this is kind of a test that I would say most folks are more familiar with. But I think understanding the head impulse test is necessary so that we can understand the SHIMP, or that suppression head impulse test or paradigm. So we're going to get to the SHIMP more formally in a moment, but let's briefly review the head impulse test, or head impulse paradigm, and let's look at that. So there are three potential planes of movement for the head that are traditionally impulsed. So one of those is horizontal. So this is our quick to the left or quick to the right. And that's the most common bedside test for the head impulse test or paradigm, I would say, as people are most familiar with this kind of quick left and quick right, trying to look mostly at the integrity of what would innervate the horizontal canals. Also, we can look at what's called RALP. So I learned this as right anterior, left posterior. So in the picture, they're showing a red line to indicate the RALP plane of testing that right anterior and left posterior. And some people will kind of make a little head dance from it to identify that plane. And then we have our LARP, which is the green line on this image, testing the left anterior and right posterior, kind of diagonal movements in my mind in a way. So this is the planes that we could be testing in the traditional head
Yes,
impulse test in full if we wanted to test all the canals. And would you agree with that, Dr. Manzari? Is that kind of the traditional planes of movement?
yes, of course, because the semicircular canals works in pair, and the horizontal semicircular canal works in the same plane, but the anterior and posterior semicircular canal on the same side are not in the same plane of activity. So we need to consider these two line of operating, because the left anterior semicircular canal works in the same plane of the right posterior semicircular canal. So you are right when you show these two type of line of exploration of the function of the semicircular canal. We must say another important thing about this plane. We use this plane in the clinical setting with, for example, the video head impulse test, and we must be we must pay more attention to the plane where we operating, since the video head impulse test is a two plane operating system. So these tools, very important tools, does not consider the torsional movement of the eye. So we must be very careful to instruct the patient to see in front of him in the classical pattern of HIMP test, because we need to consider the vertical movement of the eye, not the torsional movement. So at this moment, we consider only two planes, the horizontal and the vertical ones.
That's a very good point. And this is where this testing, I think, can feel a little bit complicated, but I think there are ways to simplify it. So let's talk a little more about our traditional horizontal head impulse test or paradigm. This, again, is the most familiar, certainly in the emergency department, if people are trying to differentiate an acute stroke, for example, from an acute neuritis. This test is something we'd like to have people be comfortable doing. where we're doing this small amplitude, quick movement of the head and looking for this inability of the eyes to stay on target, which most clinicians will say, look at my nose, right? So they're kind of the clinicians right in front of the patient. They say, look at my nose. They move the patient's head quickly, either to the left or to the right. And they want to see that the eyes stay fixed on the nose, but sometimes the eyes will not be able to stay on and will have to jump back. And we will call this a corrective saccade. And I see that most often mentioned in the literature. Is the saccadic eye movement, the eye jumping back to the target, or a catch-up saccade. You'll see a compensatory saccade. There's different terms, again, for this kind of same thing. And I'm just going to play a quick video. So in this video, we have some head impulse tests happening. Whenever the clinician is thrusting the patient's head to the right, we get a catch-up saccade or an eye jump. The patient trying to keep their eyes at the center or on usually the clinician's nose. There's a good one there. And whenever the clinician is thrusting to the patient's left, which is right there, the patient's eyes are able to stay on target, and that is a normal. So we have an abnormal to the right on this head impulse test. That's our traditional head impulse test. So this video is demonstrating a video head impulse test for the right anterior canal. You can see the clinician is moving the patient's head quickly in that plane, and then here we are testing the left posterior canal. So we're testing in the same plane, but we're doing quick back left posterior to detect that left posterior canal, whereas he's pulsing forward, then we're testing right anterior. So that allows us to get a sense of what different types of head impulse tests look like. The traditional one we just saw earlier in our talk, but this one is looking specifically at kind of different canals, right anterior, left posterior. You can do the same thing for left anterior and right posterior. So we got to talk about the value of these different tests. So we have the value of the head impulse test. We're looking to confirm the semicircular canal function. And in our instrumented testing, we can try to determine if there's any residual VOR gain. So again, VOR gain, for those who aren't familiar, if you could briefly explain VOR gain for everyone, Dr. Manzari, just so we're all on the same page about that. It's always a topic that people sometimes seem to struggle with. What does that mean to have a good VOR gain or a normal VOR gain?
A normal VOR gain is, we consider a normal VOR gain when the slow phase of the eye movement is in comparison with the head movement results with a number of 1. So the velocity of the slow phase of the eye movement is exactly the same of the movement of the head. The head movement and the eye movement are closely similar. So this type of movements, when we compare the two movements, the number we obtain is near 1, 0.8, 0.9, and 1. This is the exact value of the normal VOR gain.
Excellent. So go ahead.
But we consider for this I repeat and I underline the slow phase of the VOR of the eye movement. This is very important for us. The presence of the saccades is an interaction between the cognitive factor, see the point in front of you, and for this cognitive task, the brain use another way to see, and they call the saccades to obtain the cognitive task that we ask the patient before to perform the test.
Understood. Perfect. So what we're looking at in our picture here as an example is a normal ability of the person's eyes to move as they should to keep up with the head movement on the right side. But here on the left, we have what you would consider to be an abnormal finding. And this person likely has an abnormal or reduced VOR gain because they're not able to have the eyes move with the head as they should. It's kind of a delayed catch-up saccade type response. Would you agree with that, Dr. Manzari? That's what's demonstrated here.
Yes, yes, yes. I agree. I agree, and it's very clear that the eye go with the head, and the patient knows that the eye must be on the wall in front of him, or on the nose in front of the nose of the physician, and so he perform a corrective saccade that in this case we call covert saccades, as you can see here, and late at the end of the head movement we call overt saccades, when the saccades are, I repeat, at the end of the head movement, and they are clearly visible for our camera, our eyes, and for this reason many times the covert saccades, we are not able to see the covert saccades, so we need these tools, the video and impulse test, to verify the presence of the covert saccades in the HIMP paradigm.
Absolutely. So when we think about SHIMP, and this is where I'm going to lean on you heavily, because to be honest, as a physical therapist with, not as many different opportunities for research or access to some specialized equipment, I have never done a SHIMP. So I'm really excited to hear from you. Really, if you could explain how you run a SHIMP paradigm, where you're trying to have this clinician ask the patient to follow the moving target, and then what we're looking for with that. Can you describe what a normal response would be? And then we'll get to the abnormal on another slide here.
Uh, I want to introduce you the terms. When we talk about HIMP paradigm, we talk about a clear paradigm when we instruct the patient to see an heart fixed target. But when we talk about SHIMP, suppression head impulse paradigm, we are talking about a new command, a new task for the patient. See a target, see an object that move with your head. For example, when we are at a tennis game and we see the ball that moves from one player to the other, we have no idea that our that both the visual system and the vestibular system cooperate to suppress this reflex. Our vestibular ocular reflex drives the eye off the target at the end of the head movement. For this reason, we need a saccades in the direction of the head, totally in contrast, in sharp contrast with the HIMP paradigm. So we need a saccades in the direction, in normal subject, in the direction of the object that move with our head, because the VOR, because the slow phase of the VOR drive the eyes off the target. But we perform this task in a very short time, approx 80 milliseconds. And Crane and co-worker describe this phenomenon just in as suppression of the vestibular ocular reflex. This is very important for our daily life, and this is the trick for many patients to live with a damaged VOR gain.
Excellent. So in this test then, what I'm hearing is we would have the patient There's a moving, you keep describing tennis, which I love, but they use like a moving light, like a laser light. Is that correct?
Laser, like a laser on the head that move with
Uh-huh.
the head
With
and
the head. Yeah.
with the head, and at the end of the run of the head, the target is off, the eye is off the target, and they are before the target. So we need a suppression saccades in the direction, I repeat, of the head, that move the eye in a quick way to the target. This is the normal subject. This is what the normal subject does every day, every day with the test, but with the daily life. And at the time of the attack, there is a very strange phenomenon. The patient, at the time in acute vestibular syndrome, has the eye on target at the end of the head movement, but he is very hungry, is not happy. Why this? Why happen this? Because we are absolutely confident that we need a visual vestibular interaction for our brain to obtain a very, very psychological being well of our daily life. So we need the cooperation of the two systems to obtain very clear wellness for our brain.
Absolutely. So what I'm hearing is if I have a normal patient in front of me, I have a laser on their head, I move their head quickly, they are going to move their eyes. It's going to be a saccade, which is normal. We're going to get a jump of the eyes so that the eyes can stay on the laser point on their target, just like the
Because
tennis ball.
when we move passively the head of the patient in to the left or to the right, at the end of the head movement, the target, the laser, is in front, on the wall in front of the patient, but the vestibular ocular reflex drive the eye off the target. So at the end of the head movement, we need a suppression saccades that is in the direction of the head to regain the target of the laser, the target that we ask the patient to follow. This phenomenon is called suppression of the VOR.
Perfect. So that's a normal response. Now, we're going to play a video, which we're going to edit in later, that shows a normal response, which was put together by McDougall and Hamalgi and all our favorite folks.
This is our paper. This is our paper when we describe for the first time this to the
Yes,
scientific community, this very very
it's a,
important.
be it's a
uh,
beautiful video. So for this test, we're looking at a patient's ability to keep their eyes on a target. And we're specifically looking at this ability to suppress. So we have a patient who has to make a corrective saccade to catch their eyes up to that target. In that case, was a little ball in the video. So that was what we see in a normal SHIMP. So what we know is that the SHIMP can elicit different findings depending on if a vestibular hypofunction or vestibulopathy is acute or subacute and or chronic. So let's talk about that. So for a patient who is in a very acute new unilateral or bilateral situation, a loss of vestibulopathy, a hypofunction, they are not going to make these corrective saccades. Is that correct, Dr. Manzari?
Yes, that is absolutely correct. When we test a patient in the acute stage for an acute or bilateral vestibular loss, in the first 72 hours of this clinical phenomenon, when we use this paradigm, the patient does not perform any suppression saccades. This is in sharp contrast with the HIMP paradigm, when in the first 72 hours, the same patient perform a shower of covert and overt saccades. This is a very incredible phenomenon. But in the in after 72 hours, the patient is able, using the residual function of the VOR, to start to perform suppression saccades and at the end of the head movement. So we are now able to define the time of the onset of the disease. I am talking about also for the unilateral, that for bilateral vestibular loss. Just incredible insight in the timing of the disease due to this very, very important new test, clinical test.
Excellent. So then, can we only notice this difference with some sort of tool, like do we need a video head impulse test, or is this something that's a bedside test with no equipment?
Uh, we can use. I think in my clinical experience that SHIMP test is a beautiful bedside test, because we are able in normal to see the suppression saccades. This is just beautiful because covert suppression saccades is very extremely rare. So in this case, we are able to see the suppression saccades in normal, and in acute stage, we are able to not we are able to recognize how the suppression saccades are absent. For this reason, it is very important to instruct the patient to move the head also in the early stage of the disease, passively, to obtain a cooperation, a rapid, very fast cooperation between the visual and the vestibular system. That is the trick, the secret of a very quick vestibular rehabilitation.
Yes, don't move like Frankenstein or a monster with the head and the body together, right? We want to move that head freely. Yes,
Absolutely. We
agreed.
in our clinic, we instruct the parents, we instruct the spouse, we instruct the daughter, the son of the patient to perform at home passive movement of the head, just
Mhm.
with a Chinese lamp, €3, and we obtain a very, very good job with this patient, and they are happy in approx 2 weeks. Despite the very slow phase of the VOR, they are happy because they perform this insight into the mystery of the visual vestibular interaction.
Wonderful. It's always good to help those patients. So, all right. So, to that end, what if we have a patient in a subacute or chronic stage of this vestibular loss or vestibulopathy, hypofunction, and we do the SHIMP? They're going to look like normal. Is that correct? Because it says here that they will have that anti-compensatory saccade.
Yes, I agree. Yes, I agree. This is a very good point, because I think that uh, shimp saccades indicates the recovery of the visual vestibular interaction, and they do not need a normal vestibular function. normal vestibular VOR, but it needs just a little tiny increase of the vestibular residual function. So it's very important point for the therapist. I must say that the physiotherapist or the physician must perform SHIMP in the rehabilitation settings, just and underlie the concept that this type of patient must be encouraged to use this type of clinical tests, but in this case of rehabilitation tool to obtain this interaction. Very important for the vestibular system, but also for the two component of the equilibrium system.
Excellent. Yes. So, an aside question for me right away is if someone has what we consider to be, if such a thing exists, which I think it does occasionally, true bilateral loss, they have no residual function at all on either side, how could they present in the SHIMP?
They present at the time of the attack of absent suppression saccades. And but if we are able to say the patient, please move passively your head, and we are able to obtain a recovery. And it is not important a huge recovery, just tiny recovery of the residual function, and we are able to obtain suppression saccades. I think in our experience in approx 20 days, 30 days, and this is crucial for the patient for the visual vestibular interaction.
I see. So we might still get those and those compensatory saccades back, even in that patient, if they get any residual return, is what you're saying.
Yeah, I must say that we call this anti-compensatory saccades very important for our clinical experience in vestibular rehabilitation.
I see. Excellent. Okay. So overall, I'm hearing that the SHIMP really is allowing us to better quantify the real value of VOR gain, since it's
I
rarely effective.
totally agree. I totally agree with you. I totally agree with you.
Right.
This is the best way to evaluate the real value of the VR gain for technical problem with video impulse test. Yes, I agree. I agree.
Yes, yes. And this is right out of your article, so I figure you'd agree. But it's helpful for me to understand, this kind of difference between kind of the traditional HIMP or the head impulse test and the SHIMP is that we're not looking at this kind of sudden change from a overt to covert saccades. We're not dealing with that here. We're looking for hopefully almost every patient to get the anti-compensatory saccades back within some time frame from their initial incident of the damage to their vestibular system. So, overall, this article aimed to explore the clinical application of SHIMP and both acute and chronic phases, looking at studies, looking at the alteration of VR gain in both unilateral vestibulopathy and bilateral vestibulopathy. And they compared this bedside test to other clinical instruments. This is just kind of a summary of the beautiful work that you did for this article, this kind of systematic review of the literature, and looking at how the reappearance of the SHIMP saccades is triggered by even the slightest recovery, which you mentioned, of the VOR that's taking the patient's eyes out of the target, initiating restoration of this slow saccadic eye movement, this kind of interaction, you're calling it, between the visual system and the vestibular system. So I think the one thing that I did want to ask you as well is if we do not feel like the patient is getting an anti-compensatory saccade back, is this vestibular rehab activity? Is this like a trainable thing that we can work on? And what would that look like? I know that's kind of outside of the article, but I'm curious what you think.
You are talking about anti-compensatory saccades or compensatory saccades?
Anti-compensatory saccades. Okay.
Okay.
It sounds like something that we want to have. We want to have those. So can we
Yes,
train those?
yes, absolutely. Our physiotherapists in our clinic in Casino are able to train this reappearance of the anti-compensatory saccades, and they work very hard with the patient. But the very important thing is that the physiotherapist must learn about the passive movement of the head to obtain the return of SHIMP saccades, because active movement cannot is not of help in any way to obtain this type of return of the visual vestibular interaction. This is our experience, and the more days the patient are without any anti-compensatory saccades, the more they are so angry, and they compensate, and their compensation will be very delayed with with other implications such as psychological and psychiatric problems.
And we definitely know there's a strong correlation, unfortunately, between various vestibular problems, but including unilateral and bilateral vestibulopathy, and issues and challenges like depression or anxiety and things of this nature. And so we want to make sure we're optimizing our patients' quality of life and their ability to function in the world, as you say. So I'm imagining I'm a vestibular therapist. I'm thinking already, okay, so I have a laser or a lamp light that I can put on my patient's head, and I could put my hands on their head and I can turn their head. And I want to know a couple things. Does it matter how fast? What am I trying to do as the clinician? And then what do I instruct the patient to try to do?
Uh, I must perform the same thing that the physician does during the clinical activity. So we must perform passive head movement, not huge movement, tiny movement of the head, and instruct the patient to follow the light that move with his head. The first one. The second one, this is in my opinion, this is very important, because this is the first tool, clinical tool and rehabilitation tool that is very important and highlight the suppression of a vestibular reflex. This is a key to understand how important is suppress the vestibular residual function for the purpose of the vestibular rehabilitation. We do not have nothing similar for vestibulospinal reflex, and we also know that it is very important that we must suppress the vestibular spinal reflex in many parts of our daily activities. So you are right, you are absolutely right when you say that the patient, that the therapist must perform passively head movement of the patient. I repeat, not huge movement, but tiny movement of the head, just to obtain the return of the SHIMP saccades.
And the focus of rehab that you've seen has been these horizontal movements. Just
Yeah.
out of curiosity, any value to doing our RALP and LARP with this? Just
Yes,
curious.
yes, yes. We have the same for LARP and RALP. We are actually our machine are not able to measure the SHIMP saccades in the vertical planes, but in our experience is just the same to obtain the return of the SHIMP saccades also for vertical head movement So it's very important what you say, and we must perform in the vestibular therapist setting to obtain in the LARP and role playing the same exercise for our patient. You are absolutely right.
Excellent. And so then we don't yet, because this is to me still, I know you guys have been researching this for a while, but to me this is still a pretty new area. So I would venture to say that we don't yet have recommendations like how many minutes do I need to practice this with a patient for it to work or be valuable? Do you know what I mean by that? Like how many times a day or during the week? That sort of thing. We don't have that information yet. Would you have any clinical insight just from your clinical experience, would you say?
uh, how many times you must perform this or the patient must perform this. We do not have any recommendation. The more
Right.
they perform, the more they recover in a quick way. I have extraordinary return of SHIMP saccades just with 0.14 of the VOR gain in approx 2 weeks. So the more they move, the more they recover. It is the key to understand the message. And in other way, the physiotherapist is as this tool that is very important, and to recognize when they use this test to recognize the normal SHIMP saccades. So when they become familiar with this clear vision of the SHIMP saccades, they will be able to see when their patient perform the return of the SHIMP saccades. Is an incredible insight for our physiotherapists, and they say, yeah, they are happy. The SHIMP saccades returns for this for our physiotherapist is a joy, and also for the patient, they are absolutely happy, despite the many years to see the over saccades, the move to to become covered saccades. This is not the secret. This is
Right.
the secrets is other. This is the cooperation, and you are absolutely right when you start your talk this evening, talking about the cooperation of three systems in the equilibrium. And this is one of the secrets of the cooperation of these three secrets, visual and vestibular. And we must go inside the proprioceptive and the vestibular cooperation, and we must be able to suppress the vestibular spinal reflex. This is the new era, the new challenge for our brain.
Yes, and I think it really will resonate with a lot of clinicians out here who are performing and assisting with rehabilitation because, we love the clinical tests and we love the instrumented tests, but at the end of the day, it's what's functional for the patient. What are they able to utilize, and how can they integrate this sensory information, even if the system isn't perfect? How can we make this as functional of a system as possible so the patient can feel secure and oriented in space? And having things like these anti-compensatory saccades is just one thing on the list that sounds pretty important. So it's good to be more aware of it, and I'm excited for the future when we can maybe have some videos and have opportunity for more clinicians to get trained to feel comfortable, because this is brand new. It's not quite integrated into some of the vestibular courses or anything yet. So I think that's what I'm looking to for the future, to see more of that, so we can add this to our repertoire. But I think it's good to kind of be thinking about it and maybe thinking about adding it based on what we talked about here, even, and then we'll learn more as we go. And we look forward to more research from your team, who I know is working tirelessly to help us understand the system better and how to rehabilitate it better. And we are so grateful to you for your work. So here are some informational pieces about our wonderful guest here today. Dr. Manzari is extensively decorated and rightfully so. And so we're grateful for your work. And I like to leave this kind of last opportunity for you, Dr. Manzari, if there's anything you want our clinicians out there to know, any resources you want to recommend to them, any conferences you think they should consider attending. We're open here to hear whatever you would like to encourage us to explore from your extensive knowledge.
Sorry, I lost your last word, but can you repeat for
That's
me?
okay. Yeah, just want to hear from you, Dr. Manzari, any resources that you'd like clinicians out there to explore that you think are valuable that they may not know about. Anything that you would recommend? Any conferences, things like that you encourage folks to explore?
No, no one at the moment. Not one at the moment, but um, there will be many times to have more information and probably you were in Barani society, and this is the best way to encourage the physiotherapist and the therapist to know much more in our field. And I must tell you that there are many other conferences in many parts of the world, and one of these is the next Vertigo Academy in Budapest in the next spring, and the vestibular meeting of the Prosper Meniere Society in March in Austria. So there are many occasions to talk about this topic and other topic that is very important and of interest for our community. That includes also the vestibular rehabilitation therapist.
Yes, and I encourage everyone, regardless of your discipline, audiology, otolaryngology, rehabilitation, the more collaboration that we have and the sharing of knowledge so that we can really improve kind of the application of what the researchers work so hard to learn. It doesn't help our patients as much if the clinicians who are working with the patients don't know about it. So we really want to, this is certainly the goal of Journal Club to help disseminate, let everyone know about this different research that's going on and to really kind of clinically apply it whenever we can. So, think about your dreams, your wishes of conferences that you could attend in the future. And, even if it's a couple years out, to put it on our calendar and say, okay, this is going to be my turn to go to Berlin or to Budapest or wherever, you clinicians out there think you can make happen. So I encourage you to really go broad and really take your learning to the next level. So we'll wrap this up today and just thank you, Dr. Manzari, so much for your insights and for all your great work. And we really appreciate you.
Thank you very much, Elena, for inviting me in this beautiful hour. And we will see in the future, and we will be in touch in many other insight in this wonderful world of the otoneurology.
Absolutely. All right, everyone. We'll see you at our next Journal Club. Take care.
Take care.
All right. We did pretty good there, huh?
Very good. Very good. Thank you. Thank you.
Yes, it's my pleasure. And I know with you, the science is so deep, and all of our viewers are maybe not as, experienced with some of these tests. So we're just so glad to be able to kind of simplify it a little bit and make it feel meaningful to them, so
I'm
they can
very,
see the
very happy,
application.
I'm very happy to contribute to your idea, and very happy to have been here. Thank you very much. Thank you.